development professional, public policy expert, and human rights activist. He was a long-time Deputy Executive Director of UNICEF and Assistant Secretary General of the United Nations. Kul is currently chair of the board of anti-poverty advocacy organization Results in the US. He's also a member of the board of trustees of Oxfam in Great Britain and of Religions for Peace in the US. He is a member of the steering committee of the Global Partnership on Violence Against Children, and you can see that Kul is a multi-sectoralist. He's also a champion for the Global Partnership for Education. Kul is a recipient of the 2018 Harris Wofford Global Citizen Award, and I can share with you that Kul is an absolute delight to work with, and we're very honored to have him as the moderator for our session this morning. So Kul, I'm going to turn it over to you.
Thank you, Dan. Thank you for that very generous introduction. Good morning, dear friends and dignitaries. I'm delighted to serve as your humble moderator for this morning's plenary session on accountability. As Dan said, I currently co-chair the UN Secretary General's Independent Accountability Panel for Women's, Children's, and Adolescent Health, in short, IAP. For those of you who have not heard of us yet, the IAP began its work in 2016 under the mandate from the UN Secretary General to provide independent assessment of how well the commitments made by world leaders and other stakeholders on the global strategy for every woman, every child, every adolescent are being honored. We have been asked to be bold and to call out critical accountability gaps in achieving the ambitious goals and targets of the Sustainable Development Goals as they relate to the health and well-being of women, children, and adolescents. As such, we feel the weight of that responsibility and our accountability to all of you to ensure that collectively we all help instill a culture of accountability for the lofty promises that world leaders have made when they adopted the IWIC Global Strategy and the SDGs. We produce periodic reports and recommendations to strengthen accountability. Our recommendations are addressed to all of you, governments, parliaments, UN agencies, donors, civil society, and the academia. Our latest report in 2018 was this one on the accountability of the private sector to women's, children's, and adolescent health. And as we all know, the private sector plays such an important role in enhancing but occasionally undermining also the health and well-being of women, children, and adolescents in many countries, including here in India. Last year, we had produced another report on accountability for adolescents. And in producing this report, sadly, we found that very little by way of meaningful accountability to younger generation was actually being practiced. What a huge missed opportunity. We would like to appeal to all of you to help disseminate and implement the recommendations that IAP, these reports, have produced, drawing on much of the evidence that came from your inputs. The theme of our next year's report in 2020 will be accountability to women's, children's, and adolescents' health in humanitarian settings. So, dear friends, these days, accountability seems to be the most often repeated buzzword in international development. It has now acquired the same currency and status as terms like empowerment, capacity building, sustainability, and equity that people used to talk about much more earlier. But accountability is not just a fad. It's not just a new fad. There is a deeper reason why we are attaching so much importance to accountability. If we look back the 1970s and 80s, the world came up with very high-level, bold vision and norms, such as the Alma Ata Declaration, the UN Convention on the Rights of the Child, the CEDAW Convention on Elimination of Discrimination Against Women. The 1990s saw those lofty vision and human rights norms translated into more implementable goals, targets, and strategies adopted at these big summits of the 1990s. The Summit for Children in New York, the ICPD conference in Cairo, the Vienna Summit on Human Rights, the Social Summit in Copenhagen, the Beijing conferences on women. Encouraged by the success in the follow-up of some of those summits of the 1990s, the UN convened the mother of all summits, the Millennium Summit in 2000, which adopted the Millennium Development Goals. And attracted by the widespread attention that MDGs received, many constituencies and causes that felt left out of the MDGs lobbied hard to ensure that their favorite topics got included in the Sustainable Development Goals. As a result, the SDGs have become very broad and comprehensive. Whereas the MDGs and most health-related goals adopted by the summits in the 1990s were very precise, measurable, and doable, the 169 or so targets of the SDGs are a collection of highly desirable, but not necessarily, not all of them, highly doable goals. In the next 12 years to 2030, we run the risk that without strong accountability mechanisms, the SDGs will become a butt of cynical remarks that at the United Nations and in big conferences like this one, goals are ever set and never met. Hence the importance of accountability for results. So what do we mean by accountability? There are different notions and definitions of what accountability means. Does it mean sanctions for bad behavior, environmental damage, and human rights abuses? Or is it focused on exposing corruption and tax evasion? Or does it mean better data and monitoring? Of course, all of the above are fundamental elements needed to ensure accountability. But we should not equate accountability to just filling the data gaps. Yes, better data can certainly help in improving accountability by influencing policy making and targeting investments better. But lack of data should not be used to cover up for the lack of political accountability, for political will. Where there is political will and strong commitment to accountability, common sense can guide us to good action. And guess what? Data will follow where there is strong political commitment. So, we at the IAP espouse a full cycle of accountability. Monitor, review, act, and remedy. Monitor refers to better data and disaggregation of data to help reveal inequities and inefficiencies. In review, we stress the importance of independent oversight institutions. And under action and remedy, we focus on the policies and investments for transforming the underlying conditions that prevent women, children, and adolescents from thriving. Accountability is about ensuring fulfillment of people's rights and entitlements. It is about remedial action for course correction to rectify injustices and inequities. It is about providing redress when rights to health are ignored or trampled. And it is also about transforming the underlying power relations that perpetuate discrimination and exclusion of marginalized groups. That is why we at the IAP place great emphasis on the remedy part of accountability from a rights-based perspective. So our discussion today here will get us to the heart of all of these issues. To set the stage for our discussion, I would like to call on two distinguished experts we have from Countdown to 2030. Dr. T.S. Borma from the University of Manitoba and Professor Joy Lone from the London School of Hygiene and Tropical Medicine. So Joy and Tears, did I say Joy and Tears? No, I meant Joy and Tears. You have the floor now for about 10 minutes to set the stage for us. Who goes first? Tears, you have the floor.
Thank you very much, Cool. And good morning, everyone. Great to see so many people here after a splendid cultural event last night with a great variety of foods, of some splendid dancing and great music. And I think the sound of the sitar is still humming in my head. So what we wanted to do is to interact with you. And you need to go on the internet to be able to interact with us. And I really hope this is going to work. Well, so there are two internet possibilities, Narmada and Mhupa, and the password is right after that. Because what we want to do is to run a Menti with you about accountability. As Cool said, accountability, monitoring, reviewing, action and remedy. And we particularly want to focus on leaving no one behind. No woman, no child, no adolescent. And we're going to frame it around 4 questions. Do we know our targets? Are they important? Do we know the data that we have? Do we have the data that we need? And do we use the data that we have? And we're going to do all of that in 10 minutes. If you cooperate, and that means you have to vote. So, Joy, let's get started.
So, good morning, everybody. We've had a masterclass from Cool on accountability, and he took us through the goals of the last 3 or 4 decades. What he didn't tell you was he was probably part of setting most of those goals. So the first question, I hope everybody has Menti up, so you get online with the wireless code that you just saw.
Oh, yeah.
Go to menti.com and you enter 710709. And the thing that Cool told you about in this sweep of accountability over the last 4 decades is the amazing change that we've seen in global health, but also how those goals are set. So we went from aspiration of health for all to very small number of targets in the MDGs, mostly on death and reducing death. And now we have come to the SDGs with 17 targets. So the first question we want to ask you is, actually, do targets matter now? Are we back in an aspirational age?
Okay. So
Jesus
is anybody logged on? Right now we're on 0 people logged on. We can see the counter. Is the internet not working? The Wi-Fi is not working?
Oh, no, somebody's
We've got
on.
one person.
One smart
We've
person.
got one person on.
Yay! So the question here is, in the era we're in now, we have 17 targets, we have 1 on health, 17 goals, we have 169 targets. In our 3rd health goal, we have 13 targets. Are these targets still important to drive accountability? Do you know the targets? Do you mind? Please vote. We want to hear from you. So accountability is all about the interaction of what the people do with data. Do we really still have a focus on targets, or are we now moving to a different era? So, yep, we're doing well here. We've got 30 targets, and if you look here, it looks like some people know some targets, but they do think they're important. We have some people who think that targets don't really matter at all. But the majority at the moment, and you can vote for what you want, you don't have to go with the majority, but the majority seem to think that their targets are still important, but maybe don't know them. So I'm here in my accountability dress. You probably can't read it from there, but it says 1 maternal death is 1 too many. So this is an aspirational target, not a measurable target. In the SDG era, we have very many more targets, but it looks like most of us think that we still need them. So let's see if we know them. Let's move to the next question, please. So one of the most long-standing targets that we have is around child survival. And as Cool has laid out for us, this went back even into the 70s and the 80s, the era of Jim Grant. And in the target that we had in the MDG era, if you'd gone to any politician, they could tell you what the maternal target was. 3/4 reduction, proportionate reduction. All countries are accountable for progress. The child survival target was 2/3 reduction. So here we're speaking to probably the most informed audience in the world. So you who are most informed, what do you think the target is for child mortality? Absolute target by the year 2030, what do we want to get to? So we've got 60 votes and counting. It looks like 25 has it at the moment. And Tis is going to show us the correct answer. And the correct answer is indeed 25. Oh. So happily you are an informed audience. So 12, in fact, is the neonatal target. So one of the important aspirations of the SDGs is not just to have this target, but then to track it in countries like we did in the MDG era. But if you take this target of 25, so I congratulate you, you're the most informed audience we have tested this on. How many countries of the 195 member states have already reached 25? How many have surpassed the target even before we set it? And now we have only 12 years left to go. How many have passed that? So who has read Hans Rosling's Factfulness? Who's seen Hans Rosling's presentations? Okay, we tend to be more pessimistic than reality. So if you look at this, now 70 people have voted. I think we will call the answer Tis. You can see here that most of us think...
Sorry.
Most of us think that very few countries have already met this target. The correct answer is 118. So we set an absolute target, and none of us in this room realize that, in fact, more than half of UN member states have already met that target. So if you're holding your policymakers accountable for this target, the wording says, if you've already surpassed it, you should set equity targets. Do you know if your country has set equity targets? What are those targets, and are we able to hold people accountable for them? So that's the problem with an absolute target. It may help you drive towards closing an equity gap. The corollary that we haven't shown here is 40 countries, particularly in Africa, have to more than double their rate of progress. So there's also the steeper climb on the other end. So on that note, I'm going to hand you back to Tis.
So the next one is about, do we know the data we have on who is left behind? So since 2000, the gap in skilled birth attendance between the richest and the poorest, wealth quintiles, in low and middle income countries, reduced by more than 20%, stayed the same. It actually increased by more than 10%. What is the correct answer? Did it get smaller? Did it get bigger? Or did it stay the same? Are we making progress in our fight against inequalities with such a critical intervention, women delivering in health facilities? So I'm showing the correct answer, and the majority answered correctly again. This is a smart audience, you're right.
Very smart audience.
There's actually been progress. And look at all the votes that come after I've shown the correct answer. Very good. So we have made progress. Adolescent mortality we know much less about. So we have some gaps there. But is girls' mortality to our knowledge, higher than boys? Or is it about the same for boys and girls? Or is boys' mortality higher than girl mortality? And this is sort of the global figure that we're asking for. So what we're seeing here, and I'm going to pop up, if you have, are you holding your votes? So the correct answer is boys' mortality is much higher than girl mortality, particularly due to violence, injuries, and so we still lack good data there, but we also need to have our facts right. So these were just two little things. So let's go to the next one. Do we have the data we need, Joy?
Well, there's a question to ask a data professor, Ties. So one of the exciting things about working in global women's and children's health is that we do love to bring out those who are left behind. So we have brought from maternal and child health, the newborn. MNCH happened in Delhi here in 2005. Vinod Paul was a key part in bringing that into our top line. And then we've added all these other components. We had MCH, went to MNCH, went to RMNCH because we mustn't leave out sexual and reproductive health. Then we added the adolescent, then we added the nutrition, then we add the child development. So now we have RMNCAH, D and N plus ECD. We're on about 10 different things. But the data is not equal for all of these. So if we look at this, in your opinion, which of these do we have enough data? And remember what Cool said at the beginning, it doesn't have to be perfect data, but do we have enough data to inform reaching those who are left behind? So if you look at this, immunization is looking like a clear winner. We have a massive amount of routine data. We can split it down to the fifth child who's left behind, where are they left behind, which district. We can look at how many antigens you're immunized against. We can look at quality in the cold chain. At the moment, it looks like we believe that adolescent health really has an important data gap. Maybe for mortality, but maybe especially for coverage and quality. What's the package? What's the numerator? What's the denominator? How do we split that by equity? Nutrition and ECD may be unfair to have combined these together because we do have different levels of data even within those. But if you look at this, we have some things that we have a lot of data on, but none of these have a complete data gap. So then if we go forward to the next question, we have different types of data. And among those different types of data, which of those, in your opinion, are the best way to package the data that we have to link to accountability? So do you think that global estimates, whether they come from Geneva or Seattle, Lancet publications, social media, a lot of people get their data and their fake data from social media, mainstream media, Ministry of Health, public health institution. So this one is a more tricky, you're such an informed audience, we're giving you a more difficult question. So you have to take your 100 points and allocate them across these options. Which one do you think is the most powerful for accountability, for real change in systems, especially to reduce inequalities? So it looks like the Ministry of Health, oh no, social media is suddenly overtaken, goodness me. Social media is out in the running at the front here. Oh goodness, but the Ministry of Health are voting again. Come on, Ministry of Health people. Lancet publications are surprisingly doing well, and global estimates are really at the bottom here. Goodness me. So I think we'll call it there and hand back to Ties for his next question.
Yeah, I think some of the international folks voted first because some of these odd things like Lancet publications and global estimates came up first. But I think a good Ministry of Health report or social media are considered important. So, women and children's and adolescent health today. much action, much data, little action, little data, much action, little data, little action. Where are we? So I think there is no correct answer. It looks like most of you think there is much data, but too little action. And the others, even the little data, little action gets 12 votes. Last one. Priority actions for better accountability. You can write any text, make it short, because it's a word map. Monitor, review, communicate, use, act, capacity, transparency, inclusiveness. You can put in up to 3 words. Use. Transparency. Act. Political commitment. Review. Monitor. Inclusiveness. I think we'll get the definition that Cool gave us. That's monitor, act, transparency, inclusiveness. All the words that have already been said this morning are part of accountability. Great. So I think that this will go on a little bit, keep on voting, and we perhaps get up to 100. So that was a little interaction. Do we have enough data? Do we know our data? Do we know our targets? Do we actually use them for accountability? And I think if one thing that sort of sticks to my mind, which I probably is not a surprise, because if we had a bunch of academics, mostly, like we had in an earlier event here, I think there's a strong sense that data on inequality are so hugely important, and we must do a much better job there. But I think in here, we clearly see that the biggest gap is between we have the data, but we don't act. And I think that's perhaps one of the things that the panel will also address. Thank you very much, Cool.
Thank you. Thank you. What an animated presentation. Don't we all wish we had professors like that when we went to college? My goodness. Thank you. Thank you. Now, dear friends, I now turn to our distinguished panel. I would ask the panelists to keep in mind the 2 critical questions that Joy and Tish presented and some of the responses that we got as you make your own comment. And I would like to ask each of the panelists to try to limit your comments within 5 minutes, no more. And first, I would like to turn to my neighbor here, Joy Fumafi, who is the Executive Secretary of the African Leaders Malaria Alliance, and who also happens to be my co-chair at the Independent Accountability Panel for Women's, Children's, and Adolescent Health, a long-time leader in women's, children's, adolescent health. Joy, I recall you commiserating that when you started with the ALMA initiative, the lack of reliable data on malaria was a big problem. Even then, you managed to mobilize and motivate top African leaders to commit themselves to combating malaria. Now there is more robust data available, and there seems to be stronger commitment on the part of African leaders, not just to combating malaria, but also more broadly addressing the issues of women's, children's, and adolescent health. How did you do it? What are the lessons learned, and what does your experience tell us about how to genuinely harness the commitment of heads of states and heads of government to accountability for results in malaria and elsewhere? I turn to you, Joy. Thank you. 5 minutes.
I apologize. Thank you so much, Ku. A pleasure to be here and to participate with you in this discussion. A politician is by her or his very nature an animal that succeeds or fails based on the degree to which they address accountability for results. This is in a true democracy, of course. Now, a lot of African countries that were malaria endemic at the turn of the century were countries where the incidence of malaria was extremely high, and the mortality rates, particularly amongst children, was extremely high. Morbidity amongst adult populations was so high that it was impacting agricultural production, it was impacting production in the manufacturing sector, it was impacting education both for the learners and for the teachers. So morbidity levels were as equally important as mortality levels in these countries. So it would be very, very difficult in these countries to find a political leader who was not required to address malaria. So with the introduction of an alliance between the heads of state and government, that is the African Leaders of Malaria Alliance, it became very clear that the one tool that they required was not just access to data, but a mechanism that will enable them to intervene in such a way that they can produce the type of results that the electorate wanted. So it was logical to come up with an accountability mechanism. What was difficult, though, was getting the various countries to accept the data that was being presented to them. We had a situation where some heads of state were not comfortable with the data because the data that was coming from the international community was not the same data that they were getting from the ministries of health. But the improvements in the quality of data has led to a different situation right now. But I think what continues to be a challenge for heads of state and for even the ministries of, working with the ministries of health, has been the level to which we are able or unable to disaggregate data across age, across gender, and other critical markers of exclusion, in order to ensure that the 500 million children who live in countries where there are huge data gaps are adequately covered, so that we can properly target interventions, in order to make sure that the 60% of refugees where age data is not available are also covered. Because in refugee situations, in mobile populations, malaria is a big killer in the malaria endemic countries. Now, the data regarding to these particular populations is not available. And we have a huge number of young people who do not have access to health services, but where pregnancy levels are extremely high. And because these adolescents do not have access to reproductive health services, with high levels of pregnancy, interacting with them in order to give them access to malaria interventions, just like it is difficult to interact with them to get access to other interventions, is going to make it very, very difficult to reach them and therefore to reduce the mortality and morbidity levels among these populations. So the challenges now are finding mechanisms that are going to enable data access. And my feeling is that mechanisms such as ALMA, mechanisms that are being used by all of us to interact with governments, have to harmonize with new technologies and tools that are currently being used. The OECD Child Wellbeing Portal, for example, which makes data on children and in different settings useful in informing decision making. This should be adopted by all countries. The Youth Progress Index, which was launched in 2017, this again is a mechanism of making sure that youth data is more easily available, and then we'll be able to get youth easier access to reproductive health facilities, etc., and be able to cover the infant child. The inaugural Global Health 50-50 report. Now, all these interventions, IPU's report on the role of parliamentary oversight, Women Delivers Guidance, working with Canada on national audit institutions, all of these should be embraced by countries, embraced by all of us, because it is when we harmonize and align the use of all these tools that will be able to get access to the type of data that identifies where the inequalities lie and gives us access to more populations, so that we can then be able to comfortably say that we can eliminate malaria, we can enable access to reproductive health services, universal coverage with reproductive health services, particularly for young people, and then we can be able to achieve the SDGs. Thank you.
Thank you indeed. Thank you. Very informative. Now let me turn to Honorable Jane Drew Taching, Minister of Health of Uganda. Madam Minister, I understand that you have been using in Uganda the scorecards, the league tables to rank your districts in terms of their performance on health and nutrition. Please share with us, how does it work? How do you use these league tables to hold your district officials and health officials accountable to health outcomes? And are there any lessons that you can share that the rest of us might emulate from Uganda's experience in holding your health officials accountable for results for women's, children's, adolescent health? You have the floor, Madam Minister.
Thank you, Kul. And once again, allow me to appreciate you for inviting me to share with you what Uganda is doing regarding accountability for women, children, and adolescent health, and more specifically on the league tables. The concept of the district league tables in Uganda started way back in 2008. At that time, we were looking for a way of holding districts accountable, but also inspiring them to work harder and to be able to give accountability not only to the public, but also to the policymakers and to themselves. And so a district league table was developed that has a number of criteria that the districts are graded on. And we look at availability of human resources for health, focusing majorly on the doctors, the gynecologists, and the midwives, but also other human resources. And then we analyze the maternal mortality per district. We look at the under 5 mortality rate, neonatal mortality rate, DPT-3 uptake, intermittent preventive therapy for malaria, antenatal attendance, adolescent health, and screening for nutrition, among others. Now, this analysis is carried out on an annual basis, and results are shared in what we call the National Health Assembly, where all stakeholders and partners in health come together every year to review what we have been doing in health, and to review our performance and set targets for the next year. So during this National Health Assembly, the results are presented. The best districts are recognized. The poorly performing districts are also recognized. Not to be ashamed, but to be encouraged to perform much better. But also some of the challenges that the districts face during the year are also highlighted and identified for policymakers to take action so that they can perform better in the following years. This has been very encouraging because many of the districts are inspired to perform better because it comes with a reward. And the reward is that you receive a trophy for good performance, you receive a certificate, and you receive more funding for primary health care activities. The poorly performing, as I mentioned, do not go back with nothing, but the policymakers plan better for them, identifying the gaps that need to be addressed, and filling in those gaps so that they can also perform better the following years. The criteria for grading changes every year because we are cognizant of the fact that not all districts are at the same level. And therefore, measuring them on the same criteria sometimes is a little unfair. And so we keep on looking at the changes in disease patterns, at the changes in population patterns, at the changes in availability of resources, and we adjust accordingly. But on the whole, this has really encouraged districts to perform, and it has enabled us to identify geographically the regions that are not doing well and have their data analyzed much more critically, as is in our reproductive, maternal, child and adolescent health investment plan, so that more impactful innovations can be carried out in these districts so that they can pull up. Thank you, Chair.
Thank you, Madam Minister. It's wonderful to hear that the league table system works. I know some of us in other organizations have been using them for a long time. In UNICEF, we used to use these league tables. Not, as you said rightly, league tables are useful not just to name and shame, but to recognize and reward and encourage. I think there are many such indicators now at the global level. There's the human development indicators, the commitment to development indicators, and I'm delighted that you are using this system. I hope many other countries can do that. There is nothing more powerful than comparing yourself to your neighbor, to your competitor, to your colleagues, to improve your performance. Wonderful. Dear friends, we now turn to hear the perspective of the younger generation. I turn to Y.K. Sandhya ji, the coordinator of the Sahyog movement in India. I understand, Sandhya, that your movement is heavily involved in social accountability, I assume including through the use of the social media. As we all know, social media can be a powerful force for positive change, or as we have seen here in India, the huge scandal involving fake news through WhatsApp. Social media can be a powerful transmitter of the old saying, of statistics, but the statistics in the context of the old saying, statistics, damn statistics and lies. How are we harnessing the power of social media to promote honest social accountability in India? I would like to hear the experience of Sahyog. You have the floor, Madam.
Thank you very much, and it gives me great pleasure to be here today before you. This power of social media definitely is powerful because it enables us instantly to share the untold stories of what is happening at the front lines. It is not as if we have not been documenting cases of violation or adverse experiences that marginalized women and populations face, but we have had struggles to bring these stories before policymakers and officials. The social media power that we now have enables us to get these untold stories of the grassroots and share them instantly with policymakers. But I would like to add a note of caution to say that it is very important to verify the credibility of the sources before we share. So we need to share responsibly. And coming back to data per se, I feel that today there is much more data available. There are more sophisticated methods of collecting data. But the question that we really need to ask is, whose story is being told by this data? That, I think, is critical. In the 10 years of my work that I have done in Uttar Pradesh, most of you must have heard the state Uttar Pradesh, because it's one of the poorest performing states in the country, and it has one of the poorest indicators health-wise in India. And what we found is that through all these years, there has been an assumption that women, no matter where they lived, be it rural areas, be they marginalized community women, would be able to access, say, for instance, skilled birth attendance. And so there was this understanding that women would be able to go to facilities without any problem and access the skilled birth skilled birth assistance that was going to be provided to them. But a study of 139 maternal deaths in 7 districts have shown that this is far from the reality, especially for marginalized women and women living in hard-to-reach areas. There is also this assumption that because there's a homogeneous set of women, there is no need for disaggregated data. So there is a lack of disaggregated data. And what I feel is that we really need specific studies that would look at specific groups. Say, for instance, what is the health-seeking behavior of tribal communities living in remote areas. So we did a study in Orissa in the district of Raigada, and we found that tribal women were reluctant to actually go to facilities for birthing because they looked at it, or they visualized it as a lonely experience with no familiar people around. The language spoken was different. So clearly the global template of one size fits all is not working, and it's necessary to question and recognize this. We have also worked extensively with adolescents in Uttar Pradesh and Uttarakhand. We worked with around 3,500 adolescents, and we have seen, much like women, youth and adolescent girls are also seen as a homogeneous category, and their gendered and social realities are not adequately recognized or studied. Take, for example, and this is especially true when we are designing programs. So take, for example, the adolescent-friendly health clinics. Now, their very location is such, they are either located in districts or in blocks. And this completely negates the fact, it overlooks the fact that for most girls from marginalized communities, they do not have the adequate mobility or agency to travel from their villages to reach these clinics and benefit from whatever services are being offered. And I would also like to add a little bit about how duty bearers respond to data when we present it to them. And I think I would like to view duty bearers at 3 different levels. We have found that at the national and the state level, duty bearers are resistant to negative feedback because they have this anxiety of meeting the global targets, the national targets, and they need to present positive data that shows that we are moving and progressing towards these targets. But we see a slightly different picture when we talk about officials at the district level, and separately when we talk about health providers and service providers. What we have found in our experience are citizen advocates, and these are not just standalone individual advocates, but they are they're part of a civil society platform and a network which constantly works to advocate for better health services for marginalized women and girls. And what we found is in our engagement with them, especially through the Hospital Management Committee, these officials at the district level, they do have a sense of answerability. They are willing to engage with us and with our citizen advocates, and they are willing to make improvements in quality to establish greater accountability. When we come to health providers, however, we find a slightly different picture because they have many biases. So these biases are moral biases, there are social biases, there are religious biases, and all of these biases tend to influence their interaction with the people they are meant to serve. So take, for example, the family planning program in India. And we see that this program has completely bypassed unmarried